Washington technical issues, but I am really excited to introduce one of our colleagues from vascular surgery here at the University of Washington, Dr. Kirsten Dancy, who's an expert in peripheral arterial disease. She went to medical school at the University of South Florida and then did her general surgery and vascular surgery training at Beth Israel Deaconess in Boston, as well as a master's in public health there, where she developed an interest in quality improvement and working with Medicare data to look at the larger population impacts and longitudinal outcomes of patients with peripheral arterial disease. She helps lead that work here at the University of Washington. She does clinical work at multiple sites, and I think many of you may have worked with her already, but there's lots of exciting new things coming up in the area of peripheral arterial disease. So it was really lovely for her to come in and join us today to teach us about that. So thanks very much, Dr. Dancy.
Yeah, absolutely. Thank you so much for having me. Today, we're going to discuss some of the newer guidelines that were recently published, and we'll also just kind of go through a real brief history and physical and diagnostic approach to PAD, and then we'll also discuss really kind of guideline-directed medical therapy, and then at the end, hopefully we'll get to revascularization strategies and how we really treat patients with claudication versus CLTI, and just optimal approaches. The initial slide was really kind of pathophysiology of peripheral arterial disease, but I think that's we don't necessarily need to get into that with this audience. So just classification approach for PAD. Most of the patients, 70% of patients are asymptomatic. Most of our patients actually present with intermittent claudication, which is the most common manifestation. Most of the patients come in usually with pain in the calf, thigh, buttock, induced by exercise and relieved with rest. There's very low progression of disease with appropriate risk factor modification and medical management. And we really discuss kind of treatment of these patients once they start developing disabling claudication, so really lifestyle limiting or short distance claudication. And then for kind of the third group of patients, it's really CLTI, so formerly known as critical limb ischemia. And these patients have a high rate of limb loss without urgent revascularization. This is probably the most common classification that vascular surgeons use as far as just understanding PAD and using the same language between clinics. And so it ranges all the way from asymptomatic all the way to major tissue loss, where we're really questioning if the limb is salvageable at that point. Prevalence. So looking at PAD, it affects over 200 million people or patients really worldwide. It's an independent risk factor for MI, stroke, total cardiovascular mortality, and just poor cardiovascular outcomes. Diagnostic treatment and management of PAD alone costs over $21 billion, and that was just looking at it in 2008 in the US alone. The history and physical are really cornerstones of the initial evaluation of patients coming in with lower extremity pain. Symptoms typically involve the same muscle groups each time and not really associated with any kind of tenderness to palpation. Most patients will describe kind of a calf pain or buttock or thigh pain when they're describing claudication. There's a very characteristic when we talk about ischemic rest pain that patients will get foot pain with elevation. And there are very few things that will wake patients up at night because they're having such bad pain or discomfort. And that's really kind of one of the key characteristics that I find for my patients with ischemic rest pain. And then, patients with CLTI, anyone who has a recurrent or slow healing wound should be seen immediately in clinic. It's really, just kind of a canary in the mine. But clinical presentation, the physical exam findings associated with intermittent claudication usually is kind of dry skin, secondary to apocrine dysfunction, muscle wasting, weakened or absent pulses, reduced growth over kind of the involved muscle group. And then you can also see this dependent rubor, which is quite striking in clinic when you see these patients, or obviously patients with wounds. And I don't necessarily need to tell you guys this, but just a PSA, just evaluate both legs. If someone's coming in with a wound, it's incredibly important. We often find that patients have concomitant disease. It's not usually isolated just to a wound. The initial workup, usually we just get a standard set of labs for these patients. And then also it's important that we screen for carotid disease for these patients. And then if they have a significant smoking history, as well as kind of aneurysm disease. And now we've actually started looking at iliac aneurysms as well as popliteal aneurysms for these patients. Quick diagnostic approach. So the ankle brachial index, it's just a ratio of the ankle pressure compared to the brachial pressure. ABI of less than 0.9 is a very high sensitivity and specificity for PAD. A resting ABI of 0.5 to 0.7 is consistent with claudication, although these values are not necessarily exact. I think it's important to recognize that the diagnosis of claudication is really largely dependent on patient symptoms. In patients with very calcific disease, you'll often get non-compliant ankle vessels, and the ABI is going to be falsely elevated, and really it's just non-informative at that point. So when you can't use an ABI, we'll use TBIs and PATs. So the digital arteries are often less prone to calcification than the tibials, especially in patients with diabetes and end-stage renal disease. And so a pressure measurement is done actually on the toe, and a TBI of less than 0.7 is considered abnormal. Or a toe pressure, really, when we start looking at a toe pressure of 50, it's a good indication that the wound's going to heal, versus less than 30 is concerning for severe ischemia. And a plantar acceleration time, we really measure the upstroke of the waveform, and it's becoming, increasingly used and studied in our field. This is just an example of a full arterial duplex looking at one of my patients. They have the whole aortoiliac segment, and it really gives you a lot of detail to the level of disease and really the burden of disease. And just a brief note, as with echo or ultrasound, it's really driven by a lot of the quality of the technician, but also by the lab. And we are very lucky to have an excellent lab here run by Dr. Zieler, who is really kind of world known as far as his work with ultrasound. So in the scenario where a patient's symptoms are highly suspicious for claudication, but resting ABIs are normal, you can get an exercise ABI, and this can be used to just assess for, the severity of PAD. And so essentially you perform an ABI at rest and then have the patient walk until they can't walk any further, or 5 minutes at an incline on a treadmill. And then you repeat the ABI immediately following cessation of walking. And the ABI really shouldn't change because exercise, there should be an increase in demand that'll be matched by the decrease in vascular resistance. And so if you see a decrease in the ABI of 0.2, it suggests that the inflow is unable to match the decrease in the vascular resistance and indicative of a patient with claudication. And so we're going to move on to guideline-directed medical therapy next. And really, one of the take-home messages of this presentation is that therapy of all of these patients has to begin with modification of risk factors for atherosclerosis. So the most recent set of guidelines really discuss guideline-directed medical therapy as smoking cessation, diabetes control, lipid-lowering agents, hypertension control, antiplatelet, and exercise therapy. I'm going to run through this relatively quickly because I think that you guys have an excellent understanding. And clearly, honestly, vascular surgeons have a lot to learn. But so the mechanism of accelerated atherosclerosis from smoking, you have carbon monoxide that causes arterial wall injury, causing an influx of LDL with concomitant decrease in HDL. You get the peripheral vasoconstriction as well as an increase in platelet reactivity. Patients with PAD who smoke, who undergo revascularization are 3 times more likely to experience revascularization failure than non-smokers. And as a result, revascularization is really we consider it a contraindication for patients who are still smoking or active smoking. We've found that patients who continue to smoke, even without any type of revascularization, those who continue to smoke, 79% will progress to CLTI, whereas actually only 8% of patients who quit will actually progress to CLTI. So it's quite striking. And then, medical therapy is really more effective than simply informing patients about smoking risks and suggesting that they stop. So it really should be in the standard armamentarium of any physician treating patients with intermittent claudication. Chantix, as well as bupropion, both have data suggesting that they increase rates of long-term smoking cessation compared with placebo. And Chantix specifically is a highly selective partial agonist that over longer timeframes is an antagonist of the nicotine acetylcholine receptor and has a greater reduction of cravings compared with bupropion and has the greatest efficacy with respect to sustained smoking cessation. The goal for patients with diabetes is really an A1C of less than 7% and a fasting glucose of less than 110. We found that, diabetes is increased with vascular inflammation as well as endothelial cell dysfunction and alteration in blood cell and platelet function. Trials have shown that patients who have PAD and diabetes have 10 times the risk of major amputation compared with patients with no diabetes with the same level of PAD. And patients with long-term uncontrolled diabetes also tend to have poor renal function, leading to end-stage renal, really just compounding the risks associated with peripheral vascular disease. Management of dyslipidemia, the mainstay of treatment really is statins. We found that it's actually there's better clinical results when prescribed in conjunction with patients who undergo some type of treatment for smoking cessation. We found that there's a reduction in stroke, MI, as well as cardiovascular-related death, and an improved walking distance for patients with claudication. And really the goals for our patient population is, LDL less than 70 in patients with symptoms and an LDL less than 100 in patients with asymptomatic PAD. When looking at some of the studies for PCSK9 inhibitors, the Fourier trial studied one of the PCSK9 inhibitors and showed a significant benefit in reducing cardiovascular events in patients who are already on statin therapy. And I think it was Repatha, it showed the lowered LDL cholesterol by 59%, which led to a 15% reduction in MI stroke, as well as cardiovascular death when compared with placebo. There was a reduction in MI of 27%, a reduction in stroke of 21%. Interestingly, the trial didn't show, kind of one of the critiques of the trial is that it didn't show a reduction in cardiovascular mortality, but a lot of people think that this is actually due to the relatively short follow-up period of 2.2 years of the study. Looking at antiplatelet treatment, there's really no high-quality data to suggest that a particular dose of aspirin, at least for PAD patients, but 81 seems to be sufficient for our patient population. For those with aspirin sensitivity, we will prescribe the patient Plavix. Dual antiplatelet is not necessarily indicated for first-line management of PAD without some type of other concomitant indication. We have found that dual antiplatelet may have some benefit when looking at, a meta-analysis for some patients, but really we prescribe dual antiplatelet in the setting of post-revascularization for our patients. There's really the grade 1A recommendation to reduce risk of MALE or MACE, so major adverse limb events or major cardiac events in patients with PAD, to prescribe aspirin 81 as well as a low-dose rivaroxaban with the benefit of using rivaroxaban with aspirin has been shown to reduce cardiovascular events, including major adverse limb events in patients with PAD. Moving on to cilostazol, it is also a grade 1A recommendation for patients who have claudication to prescribe them cilostazol. This is actually a trial that was conducted with some vascular surgeons from the University of Washington. And it was a randomized control trial, 81 subjects from 3 different centers, randomized in a 2-to-1 fashion. And they were treated for 12 weeks with cilostazol or placebo. And they found that there was a 35% increase in the initial claudication distance, as well as a 41% increase in the maximum distance walked. It's relatively poorly tolerated by patients. I would say that a lot of patients have headaches or GI symptoms. But for the patients that it works, it's been incredibly beneficial. It does have a strong antiplatelet effect, so you'll get flagged for if the patient is on aspirin or Plavix. And it's also contraindicated in patients who have a reduced ejection fraction. One of the mainstays of treatment is really structured exercise therapy in claudication. The physiological changes for structured exercise therapy are not completely understood, but thought to be related to the repetitive ischemia-induced oxidative stress, as well as inflammation in the muscle beds, resulting in the endothelial dysfunction and angiogenesis and muscle composition. Exercise should be sufficient intensity to induce claudication, followed by a brief period of rest, followed by continued walking for about 60 minutes. The exercise therapy should really increase the total walking distance over time, as well as the total amount of distance walked to induce pain. And interestingly, we haven't really found that symptom improvement shows a concomitant improvement in ABIs as well. There have been multiple randomized controlled trials and really excellent data to support structured exercise therapy. Probably the most famous one was the CLEVER trial, which compared optimal medical therapy, so an antiplatelet with cilostazol, versus optimal medical therapy plus exercise therapy versus optimal medical therapy and revascularization in patients with aortoiliac disease. And after 6 months, exercise therapy plus optimal medical therapy had the greatest improvement in treadmill walking distance. And patients receiving the stent also had some improvement from baseline, but had additional costs for up to $5,000 per patient. So this really has become one of the mainstays of treatment, and it's reimbursed by Medicare. So just trying to find the structured exercise therapy is probably the biggest challenge. This is a summary actually from the BEST CLI trial. So these are patients, and we'll talk about this trial in a little bit, but these are patients who are in a randomized control trial and looked at how they adhered to best medical therapy. So 87% of patients had hypertension, 69% had diabetes, 73% had hyperlipidemia, and 35% were smokers. And they looked at how these patients were optimized over the trial time. And they actually found that only 25% of the patients were optimized with all 4 components. So I think that there's a lot of work to do for guideline-directed medical therapy for our patient population. And I think that, we've seen over multiple studies that when patients have coronary disease as well as peripheral vascular disease, they're more frequently optimized. When treated with patients who have PAD alone, I think that a lot of these prevention strategies are underused, and I think that there's a lot of data to support that we have a lot of work to do as far as improving the medical management of these patients. Just a quick discussion about interventions in claudication. There have been a couple of controversial studies looking at early peripheral vascular interventions for patients with claudication, and discussing really how that accelerates disease. Probably one of the more controversial ones looked at Medicare claims data. And for patients, the guidelines really say that we should wait about 6 months after diagnosis of claudication to intervene. And this study found that patients who had early interventions, it actually led to rates of higher later interventions for these patients. They also had progressive CLTI. They had higher rates of progression to CLTI throughout the study period. And that a physician factor, there was these procedures were more frequently happening in office-based labs, which are usually owned by the physician. So they're getting reimbursed for the office space as well as the procedure as well. And then they also found that Black race was also associated with kind of progression to CLTI as well as later PVI for these patients. I think there was a multiple stories, and this was probably the most striking. It was like a Sunday New York Times front page article that was talking about patients who had interventions for claudication and really kind of the acceleration to amputation for a certain subgroup of patients. And there have been multiple studies that actually look at worsening functional status as well as limb loss for interventions for claudicants. So I think in general, kind of my take-home message is if you don't have to intervene on the claudicant, I really try not to. And really, if the patient is smoking or not optimized on the guideline, directed medical therapy, then I really avoid trying to do any type of procedure on these patients. I think when looking at revascularization, you have to consider, 4 factors. I think you have to look at the severity of disease, if claudicant versus if the patient has CLTI. You have to understand the patient factors that go into it, the overall well-being of the patient, their comorbidities, their functional status, and really what the current limitation attributable is to their PAD. So seeing, even if I were to revascularize the whole leg, what type of benefit is this patient going to have? Also, their level of disease really is a huge component. What can you realistically expect from the revascularization? Looking at their anatomic suitability for an open or an endovascular therapy. And I strongly believe that expertise in all 4 of these issues, really understanding them to make the right recommendation for the patient, you have to kind of engage with the patient and have an informed consent conversation. Just so we're all talking about the same, on the same page as far as when I describe inflow versus outflow. Inflow is the aortoiliac segment down to the common femoral, and outflow is really kind of common femoral down to tibials. And then the schematic on the right is showing the task classification, which is just a classification schematic that describes the severity of the lesion. So when we describe aortoiliac disease, really the mainstay of treatment was open operations, an aortobifemoral bypass. It's a major operation with excellent long-term durability. It's really best for patients with long segment disease who have very small iliacs, which honestly tends to be women, and then also young patients with premature disease. Recently, there's been kind of a rise in the number of endovascular revascularizations that we do for the aortoiliac occlusive disease. And this also, you really have to decide which patient would be right for stenting. The iliacs have excellent patency, as well as when you put a stent in the aorta, it does very well. There's, it's a high flow system. And then there's a hybrid approach where we treat the common femoral disease and stent the iliacs, which also has excellent durability. Reviewing some of the literature of aortobifem versus CRAB, which is covered endovascular reconstruction of the aortic bifurcation, so stenting the whole aortoiliac segment. This was using prospectively collected, but it was a retrospective data set over a period of about 10 years. For CRAB, patients tended to be older and with a higher rate of or with a lower rate of male-free survival at 1 year. The primary patency rates, I think, are quite staggering, that they're relatively comparable between the two. CRAB had a higher rate of reintervention, but a lower length of stay and lower complications postoperatively. So one of my patients that I actually saw in clinic, she was a 52-year-old woman who was smoking initially and had short distance claudication. We had engaged with her primary care doctor. She was able to quit smoking, but however, she did develop rest pain. So this is her. Oh, this is her CT scan, which is impressive for just occlusive disease in the infrarenal aorta. And you can see that there's this huge IMA coming off in the infrarenal aorta. That's the, kind of dominant inflow to her iliacs. Her external iliacs reconstitute. So, her inflow or to her lower extremities is collateralization from an IMA as well as her lumbar arteries. She's huge epigastrics, just kind of things to notice for these patients. So I talked to her about an open operation. She preferred to try and do an endovascular repair. I was a little bit concerned, honestly, about covering that IMA. And you can see for her, I came bilateral groin access as well as radial access. Whenever you're intervening on these patients who have aorto-occlusive disease, I will recommend trying to come from true lumen one way. So if one iliac's open, it's fine to use one iliac and just bilateral groin access, but always just be kind of cognizant of what are your other kind of strategies to make sure that you're true lumen. So this is her aortogram, and you can see this huge IMA collateralization. Able to get bilateral groin access. We were able to go subintimal in the iliacs and get through and through wires bilaterally. And then kind of you serially dilate the aortoiliac segment with balloons. And so you're just angioplasting, very, very gently. So that's after just angioplasty. And you can see here, we've put in the aortic stent. Can you see in the middle screen, sorry, I have an arrow on my screen. But you can see in the middle picture, there's an aortic stent as well as bilateral iliac stents. And this was her completion angiogram. There was a little bit of disease in the external iliacs that we ended up treating and extending down. And I saw her back in clinic. I think the other interesting thing about rest pain is that these patients will get a reperfusion pain, but the rest pain is much improved almost immediately. I think one of the key kind of technical aspects of this is when you look at the post-treatment CT scan, the inflow through the IMA is reduced. And you can see that her epigastrics are still quite prominent, but not as nearly prominent as it was on the prior CT scan. So when we talk about revascularization for the infrainguinal segments, we start talking about SFA, profunda disease, as well as popliteal and tibials. And I think you can really do endo or open for any one of those vessels. I think you just understanding, what are the kind of long-term consequences. I have a certain preference not to stent the popliteal, but I think for a lot of patients, it's the right move because they are not necessarily bypass candidates. Just reviewing the BEST CLI trial, when we talk about infrainguinal disease, this was a randomized control trial of about 1,800 patients, 150 sites, published in 2022. And the outcomes of BEST CLI reveal that among patients with CLTI for whom both surgical and endovascular interventions are feasible, surgery with greater saphenous vein conduit is superior to the endovascular intervention. However, when greater saphenous vein is not available, outcomes between surgery and endovascular intervention are similar. Improvement in quality of life metrics were more often found in patients who underwent endovascular interventions, and then really death from any cause was similar between surgery and endovascular intervention, with 33% versus 37%. And you can see here, I mean, their primary outcome was looking at male, which some of the critique as far as best CLI was that this was really driven by re-interventions for endovascular, endovascular interventions, that above ankle amputations was really no difference between open and endovascular procedures. And then also Basel II also came out, another randomized controlled trial recently that compared surgical revascularization with endovascular therapy. Randomization includes stratification by clinical presentation, so Rutherford category 4 versus 5 or 6, and the presence of absence of significant infrapopliteal disease. And in the vein bypass group, there was a major amputation or death in 63% of patients in the endovascular group, and there was major amputation or death in 53% of the patients who were treated with endo. And the outcomes of basal, I mean, revealed that among patients with CLTI due to infrapopliteal disease, endovascular treatment was superior to vein bypass and the reduction of death or major amputation. Excuse me, but really death from any cause was similar between surgery and endovascular revascularization. So I think mainly, honestly, my main takeaways from both of these trials is that these patients are incredibly sick. Like, guideline-directed medical therapy is paramount, and endovascular approaches, I think, are potentially better in the short term, and surgical approaches often will have longer patency. And I don't know necessarily if I go endo first or surgery first for all patients. I think that you really have to make a patient-directed strategy for treatment. So this is a patient that I saw moving just kind of down the vascular beds to tibial disease. This was a patient that I saw who had a fourth toe amputation that was not healing, and he developed lateral ulcers. He was a 42-year-old guy who had really poorly controlled type 1 diabetes. This is his ultrasound, and you can see he has a first digit pressure of 40, so really kind of marginal perfusion to the foot at best. And what's interesting is that this is kind of classic for diabetes patients, that the femoral popliteal segment is completely clean, right? It's patent, there's no flow limiting disease, and it's really isolated tibial disease. So for him, I did an angiogram that confirms, femoral popliteal segment looks great. And then you get down to the tibials, and you can see he has inline flow through a perineal. However, that AT is quite diseased, kind of starting at the proximal at mid-AT. And then the PT is also just diminutive in the distal calf, but there's a robust DP and AT that fills from one of the branches of the perineal. So I was planning for this patient because he was so young. I was planning on doing an open operation. However, I got an echo. I pre-admitted him, got an echo that showed that he had a silent MI sometime within the past 3 months. And so after, discussing with cardiology, it's probably not, he probably wasn't the best suited for an open operation so we actually took him and we did pedal access, which is my preferred technique for patients with really profound tibial disease. And so you get access kind of distal DP, and you have wires coming from above and below, and you're usually subintimal for, throughout the occlusion, and you just do serial balloon angioplasty to try and weaken the septum of the dissection plane. And once you're able to get true lumen, usually from below, you'll snare the wire and have a through and through wire coming from below and above. And so that's what you can see here. I ended up stenting his AT using a coronary stent. And you can see that the couple things I look for on post-procedure angiograms is, the rate of filling. of the AT, and you can see that this is similar to the perineal, which had, was the dominant runoff to the foot. This is just a picture for the fellows or really the trainees. When you're looking at a DP, it is a big pet peeve of mine that if you just do a lateral shot, I actually don't think that you can confidently say that you're looking at a dorsalis pedis artery. I really do think that you need to look at a caudal shot or an AP shot with a little bit of caudal of the foot to really see that branch go between the two met heads to understand that that is the dorsalis pedis going into the tarsal branch of the foot. And then we do, for really all of my peripheral vascular interventions now, I use IVUS for sizing because we have found there's a lot of studies to suggest that we were undersizing our treatment strategies, especially in the tibial vessels, just based on sizing on angiogram. You can see the wire is still in, but you can see that there's great flow from that AT through the DP through the tarsal branch. I've seen him in clinic. He's doing great on his aspirin as well as his low dose for rivaroxaban. And then just kind of moving on, this is my last topic, but it's deep venous arterialization. It's something that I have a particular interest in. For people who are not familiar with this, it's I do all of mine percutaneous, but it's essentially transcatheter arterialization of the deep vein. It's an endovascular procedure where we revascularize patients who are no option CLTI. So they're looking at an amputation if you do not do, otherwise they're just looking at an amputation. We essentially perform an arteriovenous fistula that we create proximally to the diseased tibial artery. We use a covered stent to create that fistula. The arterial blood is diverted from the tibial vessels into the covered stent and into the venous system to essentially bypass the occluded vessels. And the venous system is really leveraged to deliver oxygenated arterial blood. It was first described in the 1800s, and it was shown to have pretty poor outcomes with poor wound healing, leading to, heart failure as well as severe leg swelling. It was looked at again in the 70s where they were doing open deep venous arterializations. And there were a couple of very small studies, but one that I found that they found resolution of breast pain or wound healing in 5 out of their 6 patients that they treated. This is just a schematic of the open or the hybrid approach. I mainly do the endovascular approach, so which is the picture on the bottom of the screen, but you can see there's an occluded tibial vessel, which is red, and you create this fistula between the vein and the tibial vessel. It's not really well understood in animal and human models. You see reduction of ischemic markers, you see neovascularization and a reduced venous lactate. So we don't quite understand how this actually works. There was recently a study, there have been a couple of studies. One meta-analysis looked at small single center trials at the literature. And for the percutaneous DVA, they found that depending on the trial, that there was wound healing rates of 60 to 71%. Most recently, there was the PROMISE-2 trial, which used one device called LimFlow, which is just a device that has now been, it's FDA approved for deep venous arterialization. It was 105 patients enrolled. There was 99% technical success, excuse me, but 93% of the patients had some type of adverse event. And you can see that for these patients, they're otherwise looking at an amputation. So limb salvage at a year is about 53%. There was a survival of 65% at a year, and amputation-free survival is still pretty low at 33%. This was one of my patients who we did a deep venous arterialization. It was an 83-year-old guy who had multiple medical comorbidities, but he was presented with fever and chills. First, you have to treat the infection. In order to do a DVA for these patients, they have to be able to wait for the venous system to arterialize, so they cannot have rapidly progressing ischemia. They can't, if it's kind of dry gangrene that's been there for a while, that would be a good patient, but a patient who has, profound infection, really it's source control is the first, is really key in these patients. So for him, he had really a patent femoral popliteal segment, and even his tibials don't look, his tibials don't look particularly diseased, but however, when you get to the foot, there's really just a desert foot. There was really no named vessel. So what you end up doing is in the middle picture, you can see you get really as distal as you can venous access, and I'll usually go PT. And what you end up doing is thread a wire through the vein, go as far as you can into the artery, just proximal to the occlusion. You put a snare in the vein as well as the artery, and then you go percutaneously through the calf with a needle, and you try and thread between both of those snares, and then you advance a wire through that needle, pulling both of those snares. So you essentially have a through and through wire, arterial access through the groin and venous access through the foot. And you'll use that wire, to deploy your covered stent. So you can see here that you end up having inline flow through the venous system, through a covered stent all the way to the ankle. And you can see here, you just then have to start lysing the valves in the foot because otherwise your DVA will occlude. A lot of these DVAs need a lot of maintenance, I would say. It's a labor of love. And fortunately, this patient, he actually did very well and is now back to walking. So I think in conclusion, you really have to medically optimize these patients. I think that that's probably the most important. I think structured exercise therapy is the mainstay of treatment with claudications. I'm very cautious with operating on patients with claudication. I actually typically don't. And then patients with CLTI should really undergo revascularization at any level, whatever endovascular versus open. I think that is a conversation really should be dependent on the patient. And thank you very much for your time. I'm happy to take any questions.
That was fantastic. Thank you so much for the tour of the lower extremities. Yeah. We probably need to think about more. So we have time for questions. Yeah.
That was a fantastic talk. I have a question regarding kind of the multidisciplinary approach to these things. Our colleagues in CT surgery and interventional cardiology have really, in our line of work, have really worked together, these multidisciplinary clinics and discussing cases. Is there such a thing in your line of work where the cardiologists are involved? And because, we probably don't pay as much attention to the limbs as we should. At least I know I don't. And I'm sure there's some optimization of medical therapy, as you gave the example. Can you comment about, is there models like that? Maybe there's one already here. Can you comment on that?
Yeah, no, that's it's a great question. We have a limb salvage service or group that meets every other month down at Harborview. But I will say that really is directed a lot to the trauma patients. It involves podiatry. Up at Northwest, we have an incredible wound care center where infectious disease, podiatry, we all share these patients, and it's been fantastic. I think that there definitely is a role for cardiology. If anybody is interested, we'd love to have a multidisciplinary clinic. Because I think you're absolutely right that these patients need a lot of care, especially the CLTI patients. They really need a lot of support, and whatever way we can do that. I come from a group where we had vascular medicine as well, and that was incredibly helpful.
20 years ago, there was a lot of excitement about VEGF and kind of growth pathways and all that.
Yeah.
Do we have to push the?
Okay.
Is that still going anywhere? Where are we with that
On-
kind of approach?
Yeah, there was a lot of stem cell therapy for kind of the desert foot. And unfortunately, a lot of those trials have stopped because they really didn't see any benefit for the patients. And so I would have to see, I haven't looked in like the most, for the past year, but I've tried to enroll multiple patients in these trials and they're not enrolling. I don't think that it panned out the way that most people were hoping for these patients. Because you're right, there was a lot of excitement around it. And I was a part of one of the trials in Boston, and unfortunately that just got shut down just because of funding.
We had an online question from Dr. Nazar about what you do if there's no greater saphenous to work with.
Yeah, you can use perineal, you can go through the AT. I mean, really dealer's choice at this point. Not to be kind of cavalier about it, but the only other option is amputation. So I will try whichever vessel. I've done a DVA twice in one patient. I don't know if I'd recommend that or do it again, but you can use whichever vessel you think is most appropriate.
Thanks for joining us this morning. I had a question about the practical implementation of the structured exercise therapy, because we oftentimes in cardiology have trouble getting our patients into cardiac rehab after MIs or for heart failure exacerbations. Are you referring your patients to formal cardiac rehab programs or sort of counseling them in clinic on how to gradually increase their exercise? What does that look like in a vascular surgery clinic?
Yeah, I would say that most of my patients, to be fair, when I'm seeing these claudicants, most of the patients are functional enough to where they still are working and they don't necessarily want to go to physical therapy, 3 times a week. So I have like a handout and a dot phrase that describes exactly what they need to be doing. And it's really great when these patients come with their partners, because the partner is usually the one that's very invested in making sure that they're staying kind of on task. And there's been a lot of programs to try and now kind of leverage like the step counter on your whatever phone or pedometers, and just using that to try and really evaluate and quantify the patient's improvement over time. So I think to answer your question, there's 2 physical therapists that I will refer the patients to if they're interested in going to a structured exercise therapy, but most of the time patients just want to do it kind of on their own.
I have a question. We'll take one more from online, but can you talk about patients with advanced kidney disease and what the techniques might be for people where you're really worried about the contrast load?
Yeah, we will use a lot of CO2. So I'll do a CO2 angiogram, which is tolerated relatively well for most patients. And I think that if it can be a little bit challenging when you're trying to look at the tibial vessels, and just try and dilute the contrast as much as I can. I think the lowest number of contrast, or the lowest amount of contrast I've used, was 3 cc's on a patient that we did a tibial revascularization on. And I did the majority of the diagnostic, as well as the completion with using CO2.
From online, a question for the deep venous arterialization. How do you prevent runoff proximally through the venous system, and do you occlude it?
How do you, sorry, when we talk about the venous system, I usually think of kind of peripherally and centrally. So the flow is coming from artery into vein. And because of the valves, I mean, I guess if a patient had, terrible reflux, that might be an issue, but most of the time the valves are relatively competent in the foot. So you actually end up creating kind of venous insufficiency in the foot in order to really kind of get forward flow.
All right, we'll finish up. I've got one last question for you, which is, we refer a lot of these patients to you. When we're in cardiology clinic, what are the things that you routinely wish we had thought of or done in advance before we sent these patients to you?
Honestly, most of these patients are on optimal medical therapy. I will usually look for kind of like their most recent labs. And if they don't have that, then I will kind of order just a lipid panel just to see where they are. But otherwise, most of them are, I prefer the referrals from cardiology as opposed to other folks because oftentimes you make my life a lot easier.
That's great. I think we'll take that. So thanks. And thanks so much for joining us today. Really appreciate it.
Yeah, no, thank
Dr.
you.
Nancy.